Hello, Professor.
How are you?
Good and sad.
Sad? I'm passing around a sign-up sheet where you can initial it in the yellow highlighted column, please. The quiz that I was planning to give today, I'm postponing till tomorrow due to the people are unsure about it. So I just decided I'll give you one extra day, and we'll do it at the beginning of class tomorrow. Okay? We're going to be doing these two PowerPoints. We're also going to be picking up on the one that we kind of had last week after the exam. I know that after exam, students are kind of in la-la land, right? So we're going to hit some points on that one too. It's taking forever to get everything open. Who is in the newborn nursery this week? Raise your hand really high. Newborn nursery. Hi, 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 hi. Higher, higher. Higher. There should be 12 people that were in the nursery, or at least 10. Higher. Arms up high. Who assessed a brand new newborn? Fresh. Fresh. Okay. Assessment findings. Let's talk about some assessment findings. Brand new newborn. Okay, if you're not brave, I'm going to call on you.
My newborn had a really weak line that went down the forehead.
Okay.
She had an internal monitor.
Okay.
On it for a long time.
So the IUPC, the intrauterine pressure catheter, left a red line. I've seen lots of red marks from the scalp electrode. That's into the skin. Yeah, okay, so that's good. So how did you document that? Or did you talk to the nurse? And because that's an abnormal finding. You want to document it, or somebody needs to.
And the nurse just explained to the mom.
Okay, good.
That's why. What's the line? Is it go away?
Yeah, so that's good. It just needs to be addressed. You can't ignore that. It needs to be addressed. Okay. Anybody else have a finding that was questionable? Yes.
Well, we had a Down syndrome baby.
Oh, you did? Okay, so what were your findings?
She had her neck was pretty much like straight down and flipped her over like from her head to her neck to her back.
So they have a really short neck.
It was like wide.
Yeah.
And she had really small head.
Small what?
Her head was really small.
Small in proportion to her body than a regular.
Covered in like peely, flaky skin.
So she was peeling. Was she overdue?
She was like,
Yeah.
she was close term, so they said like the vertex was gone. So she was covered.
Yeah, so then they peel.
So she looked kind of like an old lady because her skin was
Yeah, yeah.
She was a 4 feeder.
don't have as strong of a sucking reflex.
A lot of her reflexes were just.
Did you notice the semi-increase across her hand?
She didn't have.
She didn't have a semi-increase?
If she had like, it wasn't as distinct. They kept saying alleged, when they did the testing, she was, but like her feet and her hands they didn't have like.
What about her ears? Were the ears low set?
Really low.
Okay. So the semi-increase, all the Down syndrome babies I've ever seen, I've had a lot of patients.
And I don't know, maybe it's just like, maybe she's, I don't know, it wasn't like.
Real distinct. Sometimes it's
like I
just,
saw in the book, it was different.
okay, usually there's just one line. If you look at our hands, we've got lots of
She
lines.
had like 2 lines, like.
Okay.
It wasn't like.
But all the Down babies that I've been involved in the delivery, they have a really distinct semi-increase, so straight across the lower hand. So that's interesting. Okay. Were they anticipating a Down?
There was no prenatal care until like 36 weeks.
Oh, so very late.
They weren't. The dad actually fainted in the room.
Oh no, that's so sad. Okay, so it's completely unanticipated. A lot of Downs now are totally discovered early in the pregnancy, and so they have time to deal with it. So did he fall and hurt himself? I've had dads go down for other reasons. Yeah, it's bad when the dad goes down. Then you need a whole other nurse to take care of your new patient, right? Yeah. Not fun. All right. Okay, anybody else have any other abnormal or maybe not that abnormal? You know, just so I know with my students, if you're not going to speak up, I'm going to call on you.
That would make me call you.
What?
Laura has a good story.
Okay. Being shy. Okay, go ahead, Aurora. Let's hear it.
It was a term baby, 39 weeks, and I was born. She was 5 pounds.
5 pounds, full term.
She had a left pelvic,
Oh, it's left? Oh, okay.
and she also has this thing right. She had, what was that syndrome? Pierre Robin.
Had what?
Pierre Robin.
Oh, I've heard of that, but it's real rare.
She had her chin
The chin is kind of way back.
way back,
Yeah.
and her tongue was way back.
And is it? Okay. And were they anticipating that?
No.
I think that's a chromosomal abnormality.
Yeah, they say that it's genetic
Yeah.
mutation.
So they weren't expecting that one either.
No.
That was at the hospital. St. Joe's? Both were at St. Joe's? The Down syndrome baby too? Western Med? Okay. So, okay, well that's interesting. Yeah, so a lot of these things we know ahead of time, but I've been in the delivery room and seen all the surprises too. I've never had a dad pass out though.
If the mother tests positive for drug use, do social services just take the baby? Or?
Good question. Who wants to answer from my group?
Yes.
Because what did we have at Fountain Valley? We had a couple in the last week. Yeah. Yeah. Gave out of the field, we'll call it. Yeah, out like under a bridge, is what we were told. Yeah. And so that was a drug baby, and then we had the heroin addict patient, and then this week we had another one. So we've had a slew of drug babies at Fountain Valley. So the question was, is social service called and the baby removed from custody? Pretty much yes, yes, yes. Especially because the baby had the urine bag placed on it. We get the first void of the baby. If that comes back positive, guaranteed that baby will not go into the custody of the parents. I know we had the grandmother was present at the one delivery of the heroin addict, and I was thinking potentially the grandmother will gain custody, because I know in past cases they try to get a family member to assume custody of those babies. It's really sad though. It's really sad. And those babies have feeding issues usually. They're kept longer for observation. because they have initially poor feeding. So, yes, question?
You said it's mostly the foster. Usually we have a contraction, flaring nostril, and difficulty.
So, signs of respiratory distress. So, nasal flaring, retraction, and what's the third thing that you should know about respiratory distress? The third sign. Grunting.
Oh, is that?
Yes. And what does the grunting sound like? It's the cutest little baby sound, okay? You're going to think, oh my gosh, that baby's like talking almost. You know, when you think of grunting, you always think of something like really negative. But when a baby is grunting, it's an expiratory grunt, and it's just like, little newborn thing. It sounds really cute, but it's not. Like, we want to document that. We want to keep a really close eye on any baby that's grunting. Okay, so it's an expiratory. So you should know those three signs of respiratory distress. Okay, you should make a note to yourself. Note to self, you should know those three signs. And you should be assessing all babies for those continually through that first 2 hours of observation. Okay, we had two babies, I think. Maybe just one baby, the one vaginal delivery. Cap, that was your baby. And what about the head? That patient was completely dilated at 7 a.m., and she didn't deliver until what? Almost 2 o'clock. Yeah. So, yeah, patient was completely dilated at 7 a.m., didn't deliver until 2 p.m., okay? So what do you think, and it was a vaginal delivery, what do you think her head was like? Complete cone head, right? Overriding sutures. We expect that, okay? So we're going to expect a molded head, overriding sutures. And if you have the chance to palpate overriding sutures, if your baby has that, get all your classmates over that are in the nursery that day. Everybody palpate those, because you need to know what that feels like. That's a good assessment planning. And I was really happy. There's one of our graduates was just hired to work in L&D at Fountain Valley, and Monday was her first day, and she just graduated in the fall. And so I was so happy to see her. She smiled really big when she saw me. So because it's really tough getting jobs initially right now in Orange County. A lot of people are not retiring due to the recession. So that was really nice. We have an insider. That's how I look at it. We have an insider now in L&Z. So very, very excited for Tina. Anything else with newborn assessment this week in clinical? Anything that you saw that you had a question about? Yes.
I have a question. It was kind of happy.
Okay.
I guess the dad, when she was pregnant, he would talk to the baby all the time. So when the baby came out, he was talking to the baby, and the baby's eyes were so big and just looking around like, I know that voice. And he was concentrating so much, and we were just like, oh, he's actually listening.
And I've seen that time and time again. We had a baby. Who had the baby that just kept crying? Oh, Colleen. She's sick today. Colleen had a baby, a C-section baby. The baby just kept crying throughout the assessment. And I kept asking the dad, talk to your baby. Because I've seen that. When the dad talks to the baby, all of a sudden they're like, I know that voice. It's really cute. I'm glad you saw that, though. But they know that voice. Because they can hear it in the uterus. So that's exciting you saw that. Yay. Okay. So I'm going to go through this kind of quick because we did hit on these issues when we did our questions on Thursday. But there were just a few things I wanted to bring to your attention. The physical, on bullet number 2, well, actually these first 2 bullets under the concept, this is what should be on your concept map regarding the risk of ineffective thermoregulation, is that the baby has a decreased amount of subcutaneous fat and the skin is thin and vessels are close to the surface. That's the issue with our babies. So put that on your newborn concept map if you haven't done it yet. It needs to be there on your nurse's diagnosis. Okay, let's keep going. We're going to go quick. Let's see. Understanding that the non-shivering thermogenesis is how they're going to try to keep warm. Babies do not shiver like we do when we're cold. Okay, they have what's going on is called non-shivering thermogenesis. Okay, that's an important concept for you to remember. And so if they get cold, they're going to metabolize that brown fat, and then what's going to happen to their blood sugar? It's going to drop. Okay, so understanding that concept is very important. So any baby that comes to us cold, we're going to be thinking, oh my gosh, I hope this baby hasn't been cold too long, because now we're going to anticipate a drop in blood sugar. Okay, so be thinking that. You get a baby cold, we're going to warm that baby up, but be thinking, okay, what's going on with the blood sugar too? Okay, what else is here? So respiratory pattern, the number one sign of hypoglycemia in the newborn is jitteriness, and the second sign that's close behind is tachypnea. So anytime you have a baby whose respiratory rate is higher than 60, we're going to be thinking maybe this baby is hypoglycemic. Okay. Okay. And have most of you listened to the baby's heart rate? How many of you have listened to the heart rate? Is it so hard to do that at first? Is it just going so fast? I know. The more you do it, the more practice you get, the easier it becomes. But you do want to listen for the full minute. Okay, we don't want to just listen for 10 seconds and multiply by 6. Not on the initial 2 hours that we're watching that baby. Okay, we want to be listening for murmurs. The baby might have a patent ductus arteriosus, which is a very common murmur for the first 24 hours. So if you hear a nurse say, oh, this baby has a PDA, patent ductus arteriosus, that's the most common heart murmur, and those usually correct within 24 hours. However, they may take several days to correct, and you might see a baby having an echocardiogram. They just want to verify that this is just a patent ductus arteriosus. Okay. And then again with oxygenation, we want to listen to the respiratory rate for 1 full minute. A baby can commonly have apnea for 10 seconds in that 1 minute. This is the very first time their lungs are functioning. So it's important to remember, this is the first time lungs are functioning, first time once that cortiscal liver is functioning. We have 2 very immature organs, the liver and the lungs. Okay, so we'll listen to a full minute. When in doubt, have somebody else listen to your respiratory rate. If you think this rate is too low, this rate is too fast, or you're unsure, have somebody else listen. Also, listen to different areas of the lungs. There's some areas that you can hear a lot better than others. Try to use the little stethoscope with the little tiny bell, because otherwise you're going to be hearing bell sounds, respiratory rate, and cardiac sounds all at the same time. So, a little challenging. The bulb syringe, have any of you used the bulb syringe? Yes. Okay, good. What's the proper use of a bulb syringe? We squeeze it, put it into what first? The mouth first, to the sides, yes. And then we aspirate our contents, and then where do we go from after the mouth? Into the nares. Okay, then we'll do the nares second. But that's important to remember. And when we're going to teach that to the parents. We're going to teach the parents how to use a bulb syringe. Really important that they understand proper use. And again, on this slide, you have observing for signs of respiratory distress, retractions, nasal flaring, grunting. Those are the main 3. But tachypnea, anytime a baby's having tachypnea, we're going to want to really watch that baby closely. And probably attach an oxygen saturation monitor to that baby. We want to make sure this baby is satting well. Okay? What do we expect on a saturation on a newborn? Greater than 93? Yeah. Preferably, I'd say 97 to 100%. We really want to see them satting well. But yes, for sure, greater than 93. We probably won't intervene if the baby's greater than 93. When we put a baby on and the baby's like 79%, 80%, 85%, we will do interventions for that baby. And we'll watch that baby. This is a sign of sepsis in the baby. Okay? So most likely that baby's going to end up in the NICU. All right. Keep going. Washing hands, can't stress that enough. Especially if you're going from one baby to another baby, very important to wash your hands in between those patients. If you're in the nursery and you have a couple patients, okay? Once the baby has its initial bath, we don't need to wear gloves just to do routine things like wrapping the baby up, putting the t-shirt on. If you're going to change a dirty diaper, we want gloves on, okay? But otherwise, after the bath, we don't have to wear gloves every time we touch the newborn. All right? Okay. Let's see what else. The meconium. chart if the baby passes its first meconium anytime during our initial assessment, if the baby passes meconium right after delivery. We just want to make sure this baby's intestinal tract is functioning well, and they might not pass their first MEC for 24 to 48 hours, but we don't like to send babies home without them passing that first meconium. Okay, and what else? Voiding, the baby's going to void the first 2 days much less. We anticipate that. We're going to tell the mom, please let us know when you change a diaper. If the baby has voided 2 to 6 times is normal in a 24-hour period. After that first couple of days, once the baby is feeding well, we anticipate 6 to 8 wet diapers per day, or every single time the baby feeds. So that's important for you to know that. The urate crystals are common. If you get to see those, grab your neighbors and show them. It's cool when you see the little urate crystals, which we anticipate due to the renal tubules. They're not quite as mature as like an adult patient, so you might see those little urate crystals in urine. Okay, so let's see. SGA, LGA, we're going to talk about those today. Babies that are at risk for hypoglycemia, we're going to watch even closer. Those are our babies that are, the mom is diabetic. Baby is large for gestational age, 90 percentile and higher. Small for gestational age, 10th percentile and lower. And then IUGR, or intrauterine growth restriction babies, we're also going to watch them. So again, we will automatically start AccuChecks on those babies. There's a protocol. We'll do one immediately after birth. Depending on what the blood sugar is, we'll determine if we're going to give the baby a little formula or not. Okay? 45 is usually the cutoff. If the baby's blood sugar is 45 on that first check, we'll most likely intervene and give that baby a little bit of formula. And then, yes?
The first time we checked, it was 31.
Okay.
And then we did it right after, and it was 45 because it wasn't enough blood the first time.
Okay.
Just wanted to make sure.
So you had an abnormal low, so then you rechecked it. Okay, then it was 45, which is better than 31. 31 is pretty bad. So, okay, good. So we'll check their blood sugar. If it's 45 and below, we'll feed that baby at least 20 mLs of formula. That's usually what we do if we're in the nursery. If we're at the bedside, we could actually have mom breastfeed if the baby's able to latch on and breastfeed. If we're in the LDRP, we could actually do the breastfeeding there at 45. If it's lower than 45, we'll most likely do the formula instead. Okay? And then usually we do one initially, and then we repeat that in about 30 minutes after our intervention. And then if it's stable, 2 hours after that, 2 hours after that. So we're going to follow our hospital policy and procedure, but it's usually a total of 4 AccuChecks. All right? Okay, now this is just showing where to do the stick on the baby when we're doing our heel sticks. We're trying to avoid all these structures. That's why we're going to these outer edges of the heel. So this is extremely important. We're never going to stick the baby in the center of the heel. It's always to the 2 sides. How many of you have gotten an AccuCheck on a baby? Yay, a lot of you. Okay, good. And we always wipe off the first drop, right? The cord stuff. What are we teaching parents about this cord stuff?
Water.
Yeah, clean it with water. Keep it
Dry.
right. And how soon will it fall off?
10 to 14.
Yeah, 11 to 14, depending on what research you're looking at. But we tell them just leave it alone, keep the diaper off of it, right? Keep that area open to air. All right. And then we don't want the baby doing a tub bath as long as the cord is still attached. Okay, we're just doing sponge baths on those babies, even when they go home. Once the cord is off, they can put them in a little tub, but not until then. Okay, and then have you all seen Mongolian spots? How many of you have seen Mongolian spots? Okay, good. So we know those are normal birthmarks in the what ethnicity? Hispanic and Asian. Most of the babies have Mongolian spots. We just want to tell the parents it's normal birthmark. It's usually going to fade within 1 to 2 years. is acceptable. If the baby loses more than that, then we're going to encourage mom, if she's breastfeeding, to follow each breastfeeding with a little bit of formula, just to add additional calories, to try to get the baby's weight back to where it was. Okay? Okay, what else? Oh, there's my baby food commercial. Isn't that awesome? That's cute. Okay. All right. Any questions on that?
Yeah, you said the first sign of hypoglycemia was the kicking, what was the second?
The number one is jitteriness. In a study that was done, 65% of babies had jitteriness, and then 58% of them had the tachypnea. So those are the two most prevalent signs. And how many of you have seen the jitteriness? Okay. And it's usually their little hands are like this. Okay. They're not shaking because they're cold. Just get that idea in your mind. We shake when we're freezing, right? Babies don't do that. They have non-shivering thermogenesis. So when we see a baby jittering, we're suspecting low blood sugar. Okay, not that they're cold. All right, so let's go to hyperbilirubinemia. Any questions about all the normal newborn assessment findings? Also, in this handout that Monica gave to everybody, there's a great one on the newborn. I really like this. And so I would encourage you, on this handout, in front of it looks like that. On page, well, it says page 120. There's just an excellent, just a really nice, there's a good information on this. This is a great little paper to study off of. It's really, I love all these. They're just so cute and to the point. Okay. All right. So, have any of you taken care of a baby? Did everybody sign this? Okay. A baby with hyperbilirubinemia. Did you sign this? Anybody take care of a baby with jaundice? Anybody take care of a baby with jaundice? Anybody take care of a baby under the light? Okay, so you have time. Okay, so the TCD stands for what? It's at the meter, right?
Morgan and I got to go to the NICU and see babies that were under the light with a little shade.
You did? That's awesome. So the babies were under the light with their little eyes covered.
And she actually took them off while we got them out of the,
Right. You can take off their little eye gear and bring them out for feeding. Yeah, good. So, do you remember, did you see the flow sheet and what you're assessing those babies for?
We came up just to help them out.
Okay, because they were swamped?
Yeah, we just fed them, changed them, took their temperatures, and then put them back in their little crib,
And what were they wearing under the light?
Nothing, just a little diapers.
Just a little diaper. We want as much skin exposed as possible. Were they laying on the Billy blanket?
Yes.
Okay, so that's really double lights. Okay, awesome. Okay, so this is a really important concept to understand about hyperbilirubinemia, because the majority of babies will have jaundice, right? And what's the majority of babies going to have? What type of jaundice? Physiologic. Okay, or they call it breastfeeding jaundice a lot of times. So our jaundice is primarily caused from what? Okay, one person said, you're all saying at the same time, it sounds really good. You're getting it. The breakdown of red blood cells, right? And so what comes out of the broken red blood cell? Bilirubin, right? And then what's the part of their body that's having trouble getting rid of this? It's the immature liver. So once again, here we have immature lungs, immature liver. So we need to understand that this baby's going to have trouble getting rid of this extra bilirubin. Okay, so we're going to be assessing these babies. Did you assess the jaundice before you fed them? Because the jaundice usually is going to start up here in the face, and then we're always going to look at the baby's trunk and see how far the jaundice goes down. And we're going to chart that. So, okay, that was nice. You guys helped feed them. It's really important to keep them fed. Okay, so we have our baby, our little jaundice baby, and so we have what kind of bilirubin? Unconjugated. We want this unconjugated bilirubin to become conjugated so they can excrete it. So that's the important pathophysiology behind it. Until they get it conjugated, it's not going to be able to be excreted. Okay? Okay, so next point. Liver changes fat soluble into water soluble called conjugated. Yeah, so understand we need it to be conjugated, broken down, and changed. We used to think we could give these babies lots of water in between their regular feedings because we thought it was coming through the urine. And then with years of research, we discovered, nope, it's coming through the duodenum, it's coming through the intestine. So we want these babies having multiple bowel movements, not just those extra water. We want them having extra food feedings, extra formula, or extra breast milk feedings. All right, so that's our goal, is to get this baby pooping. Okay, we want to tell mom that. We want your baby to poop a lot. Okay, with every feeding, ideally. Okay. Factors associated with hyperbilirubinemia. Did anybody have a baby that had any sort of bruising on their head? Any sepelhematoma, any sort of extra bruising? Because this extra bruising is a contributing factor to our hyperbiliary babies. So if a baby has any bruising of any type on their body from anything, we're going to anticipate more of a jaundice issue with those babies due to the increase of RBCs that are being broken down. Okay, so does all that make sense? Just an important concept on the normal newborn. All right. Okay, so let's see. Understanding that their RBCs have a shorter lifespan, 2/3 that of the adults, so they're all at risk. Okay. So the liver immaturity accounts for this insufficient ability of this enzyme. You don't need to know the name of this enzyme. This is just here for you to understand, because you've had anatomy and physiology, what's going on in the body, and the issue with the babies. All right? So don't spend too much time on that. So our risk factors. This is really important for you to understand. Which babies are more at risk for developing jaundice? Okay, the first one is delayed what? Delayed feeding. Good, Anne. Yeah, so one of the reasons we want these babies breastfeeding immediately, this is one of the reasons. We want them to decrease their chances of becoming jaundiced. Okay, so any baby that has a delayed feeding, let's see, we had a C-section the other day and the mom ended up hemorrhaging, and I know she wanted to breastfeed, but I know because when I saw her, when we went to admit another baby, she looked terrible and she was hemorrhaging, so she was definitely, this is going to be a delayed feeding for that baby. This would be a good baby to do a little gavage formula feed. Trauma at birth, I just mentioned. So anytime they have any bruising on their heads, anything that would increase the number of RBCs being broken down. And then our third baby is what baby? Cold stress. So if we have a baby coming to us cold, they're at increased risk now for being jaundiced and having hyperbilirubin. So those three factors, if you're the nursery nurse and the mother-baby nurse watching baby and mom together, these are your babies that are most at risk for being jaundiced. All right? Okay, so there's two types. I just mentioned the physiologic, and as you can see, jaundice in their feet is approximately 5 to 7 would be their bili. And then if it's on the mid-abdomen, 15. If it's all the way to their feet, and their belly is as high as 20. That's really high. That baby definitely needs to be under the light. They used to put babies under the lights a lot more prevalently than they do now. Now I know for Kaiser, because my grandbaby was born at Kaiser, the number was 18. If her Billy got up to 18, she was going to be readmitted back into the hospital for Billy lights. Because she was jaundiced, and it was all because of My daughter wouldn't listen to me about breastfeeding. No, so, but yeah, she went up to like 17.9, almost got a grade, but she was really small. Okay, so just understanding, if we see the jaundice face, we kind of expect that, but we're going to want to unwrap the baby, pull up the t-shirt, see if the jaundice is going down the trunk and down into the extremities, lower extremities. And then the pathologic occurs during what? The first 24 hours, so the first day. And this is due to the ABO incompatibility. So if mom is type O, these are babies that are at risk for being incompatible. So if mom is O and baby is at A or B, that's what causes the incompatibility. Okay? So all type O moms, that cord blood should be sent. And then any Rh negative moms, that cord blood should automatically be sent for these incompatibilities. All right? Any questions about that? Yes?
They say the first 24 hours is going to for jaundice and stuff. Why is that?
That's what the ABO incompatibility is.
The blood.
So, yeah, if mom is O and her baby is A or B, and then the A or B crosses back into mom's blood, that's going to cause antibodies to be formed. So, same thing with Rh negative moms, if she has an Rh positive baby. Those antibodies come back into mom's bloodstream, causes her to become sensitized. So, these babies that were pathologic, they're going to become jaundiced much more quickly. And if you have a baby that's the first day within 24 hours and they're jaundiced, the first thing you want to look at is, what's mom's blood type? And did we get the cord blood results back yet? And let's see what's going on with baby's blood and mom's blood. Okay? So that should be our first question. If baby's getting jaundice in the first 24 hours. All right? This third bullet, if mom is sensitized and it's not picked up and it's not dealt with, the baby can end up with hydrocephalus, and I've only seen one baby born with that, and the baby, they're terminal, they're not going to survive it. The baby was completely edematous, head to toe, and it got completely missed somehow. And she had prenatal care, but I'm not sure what had happened, how she became sensitized, and it didn't get picked up. So it's lethal to the baby. If mom becomes sensitized, nobody picks it up, and she has a subsequent pregnancy after the sensitization takes place. All right? Okay, so the prenatal blood type and Rh factor, that should be on mom's chart from her first prenatal visit. They're going to get mom's blood type and Rh. So we should basically know her blood type from after her first visit on. All right? If she comes into the hospital with no prenatal care, we will type her blood immediately upon admission. It's just really important for us to know her blood type, her Rh factor, and then once the baby's born, getting the baby's cord blood sent. The D antibody, for the Rh positive moms, we're always going to be looking to see if they're positive for this D antibody. I can remember patients who were D, had that antibody. Anytime a mom, okay, let's say she's Rh negative, and she has a bleeding episode throughout her pregnancy, she should always get the RhoGAM injection. Have any of you heard about RhoGAM, saw the nurse give RhoGAM, or offered you to give the RhoGAM? Okay, so this is for Rh negative moms, and they're unsensitized to our knowledge, so we will give RhoGAM in an attempt to keep her unsensitized. It's given at 28 weeks to all Rh negative moms. Any episodes of bleeding, if they've ever had a miscarriage or an abortion, they need to get the RhoGAM following that. But it's very, very important. Amniocentesis. If they do an amnio, we should give her the RhoGAM too. There's that chance. Premature separation of the placenta or an abruption, she should definitely get the RhoGAM. Okay. And then the indirect Coombs test is done on mom's blood, and it's to determine antibodies to the Rh antigen. Okay, so the Coombs test is done on the baby's cord blood. Indirect Coombs is done on mom's blood. Write that down, highlight that, note to self. You should be aware why we do a Coombs and why we do an indirect Coombs on mom. Okay, we're looking to see if she's sensitized. All right?
Is it the same as anybody's screen?
No. The antibody screen, that's what I was talking about, the D antibody is the most common. No, they do an antibody screen on mom. If she's Rh negative and she's had pregnancy, she's had children, we will always do an antibody screen on her to see if she has antibodies. Yes?
Can you define what you mean by sensitized?
Sensitized? Okay, so if mom is Rh negative and she has a baby Rh positive and she doesn't get the ROGAM, okay, now that the baby's Rh positive antibodies have crossed into her bloodstream, and now she's got all these antibodies in her bloodstream to fight against those positive Rh factor cells. So now she's sensitized. So now any subsequent pregnancy, that baby is at risk. Okay. So it's not the current pregnancy that is the issue. It's the subsequent pregnancies afterwards. Does that make sense? There's a really nice picture in your book showing how mom's negative, baby's positive, and now mom develops antibodies to that positive, and now her bloodstream is full of both. Okay? I know it's confusing. We'll keep revisiting in Module 4 again, the whole idea. Okay, so ROGAM is given at 28 weeks if the indirect Coombs is negative. Indirect Coombs negative means mom is not sensitized. All right? If mom has an indirect Coombs and it's positive, we are not going to waste our time giving her ROGAM. She's already sensitized to these Rh positive. She's already developed the antibodies against Rh positive blood. Okay?
So what happens if the mother is sensitized and she
She has another baby? That's what happens. The baby ends up with hydroxypitalis, completely edematous, basically in heart failure. They're born and they don't survive.
We really cannot do anything to prevent that to happen.
Yeah, if they pick it up during the pregnancy, they can do things. They can. They can intervene with the baby in the uterus still. Yes. They can intervene and they can save the babies if they pick up on it. Yes, good question. Okay, so if indirect Coombs is positive, a titer is determined. If the titer is 1 to 16, then that means she's sensitized. Now this baby is at risk. So now we're going to do an amnio to look at the degree of sensitization. And what happens is that amniotic fluid will be like jaundice amniotic fluid. And they're going to check to see how severe it is. All right? So the optical density. Anybody get to help with an amniocentesis anytime this semester? No, anybody at the maternal field testing center? Oh, so you have to see one. Okay, good. So when moms have these amnios, and yours was done for, were they checking lung maturity on the baby? Was she a diabetic mother?
Diabetic.
Okay, so I was wondering the reason. There's different reasons why they might do an amniocentesis. How far off was she? Around 28 weeks? Okay, so that, I'm not sure. Or 36, yeah, probably 36 if they're going for lung maturity. They'll do amnios if the AFP, the alpha-fetoprotein on the mom is high. They like to recommend doing an amniocentesis at that point, but that amnio is between 17 and 20 weeks. And I personally discourage anybody from ever getting an amnio at that gestation because you run the risk of infection and losing this pregnancy. So that's me, as with my experience. And I've seen patients lose their babies after amnios. If they do the late one, like this one with the diabetic mom, they're looking for fetal lung maturity. They're looking for two things, LS and PG, two different levels. You know, if we can deliver her and get a mature fetus that can actually breathe on their own without assistance. So there's different reasons for amnios, but not a good idea. But this amnio would be really important. This one would be highly recommended. I would support this one because it's going to save the baby's life, basically. Okay, so again, we've already talked about getting the cord blood, getting the baby's blood type and RH. If the baby's RH negative and mom's RH negative, there's no problem. Okay, so that's the goal. If RH negative mom, then she has RH negative baby, then there's no problem. If she's positive, then we'll give her ROGAM within 72 hours of delivery, as long long as her indirect case is negative. Okay. Okay, so these nurse actions are really important. I want you to highlight these. You should be aware of our nursing care, how we're going to be taking care of a baby with hyperbilirubinemia. The bili levels, now they're using the meter. I don't know if you've seen them use the meter to do the bili externally instead of drawing all these extra labs. The meter's really nice. It just goes against their skin and checks the bili level by the skin. If a baby has really high bilis, they'll do the lab draws, and we used to do our own through a heel stick, or the lab will be called. But you want to keep a close eye on the bili levels. If these babies go with high bilis for an extended length of time, it can cause brain damage. Same thing with low blood sugar. If a baby goes with low blood sugar for a long time, it can cause brain damage. So we should be aware of our bili levels, and then the level of jaundice. Every 12 hours, you should be charting the level. Is the jaundice all the way to the baby's feet still? Was it all the way to their feet and now it's just to the mid-abdomen, or is it just in the face? We need to chart that. The number of feedings. Those babies should be feeding very frequently. If it's a breast baby, every 1.5 to 3 hours, no longer than that. If it's a bottle baby, every 2 to 3 hours. I mean, we want to keep these babies, keep their GI tract moving. That's what's going to bring their bili down. We want to keep a close eye on their temperature because, as Mari said, that the baby's just in a little diaper. That's it. They're in a little warming, like incubator unit. So we got to keep a close eye on temp so we don't add cold stress, or we don't overheat them. The same problem. If we overheat them, it's not good for their metabolism. Okay, and then if we do suspect hypoglycemia, we'd want to do an AccuCheck. But the lethargy, poor muscle tone, decreased or absent moral reflex, these are all signs and symptoms of the jaundice. So you have a baby that's lethargic, poor muscle tone. This is due to the hyperbilirubinemia. These are normal findings. So we'd want to be assessing this at our regular intervals, probably like 4 hours. Okay. And then we're going to manage. We're not using water anymore. It's all formula and breast milk for these babies. Breastfeeding frequently. Formula, I'd say Q3. I don't think they let babies under lights go 4 hours in between feedings. They want to keep them moving. Preventing cold stress and hypoglycemia. And then managing the phototherapy. How far away should the legs be from the baby? So 12 to 30 inches above the baby. You want to just make sure they're not too far away or they're not going to do a very good job. Okay? And we can have the bili blanket underneath, cover the eyes. It's really important because they do move around and their eyes can become uncovered. We just want to keep their eyes covered and keep their eyes protected. And then we want to change their position every 2 hours. And then their skin is really important to be checking because we want them having a lot of stools, but that can cause skin breakdown. So we want to keep a really close eye on their skin. Okay. All right, those are our evaluations on our nursing diagnosis. Okay, does all that make sense? Okay, good. Any questions about hyperbilirubinemia? Yes, Rod.
What is the preterm or
What? Preterm babies high risk just because their bodies are so much more immature. So, yeah, they're all immature and then you put preterm on top of it. Yes. And smaller. Any other questions? No? All right, let's look at our IUGR. Okay, everybody stand up for a minute and stretch. You're looking really tired. You're making me sleepy. Yeah, stand up and stretch. And then we'll take a break in 10 minutes. for exam review. I have some people signed up. Not enough. She aspirated. You aspirated. Take that. Yes? Yeah. It's right next to my office. Yeah. The sign-in sheet for the exam is right next to my office door. So, yeah. It's for today and tomorrow. Yes.
How come it's not this? You see, like, there's this coloration first in the face and then the body. Why can't it be from the center of the head?
Good question. Yeah, I don't know. Yeah, like it's just from the center of their abdomen. No, I don't know. Good question. I'll try to find out. How's that? See, there you go. Listen to Betsy. Say that really loud.
The blood comes out of your heart, up your arteries towards your head. And if the blood lies right there, that's where it comes. Before it gets down to the liver.
See, very good. Yay. Yay, Betsy. Go, Betsy.
I thought the face was, more competitive than the side.
No, but it's true. Like the majority of the oxygenated blood goes right up into your brain. Amazing how that works. Okay. All right. Does anybody recognize that couple in the background?
Yeah.
Who is it? It's the Duggars. They have 19 kids.
Whatever.
I know. And her last one was a C-section, premature baby, and she still didn't get her tubes tied. I'm like, whatever. Anyway, and then they had 19 babies, all natural deliveries until that one. I think, yeah. Okay, so let's go back to. All right, so IUGR, they used to call it intrauterine growth retardation back in the day. Now we call it intrauterine growth restriction. It's important that you understand babies who are IUGR, if the insult to their growth happens early in the pregnancy, it's serious. And those are going to be the babies of like drug addicts who are, mainlining their drugs and malnourished. What's going to happen is it's going to cause their organs, their vital organs, to be subnormal, small and subnormal, just not well formed. So these babies are at much greater risk of having problems, major problems. If the assault on the baby happens later in the pregnancy due to a high-risk condition like preeclampsia or diabetes out of control, then the organs are normal organs, but they're just going to be small. Okay, so it's important to know what's happened to this pregnancy. When was this little forming fetus affected? Okay. Okay, so genetic predisposition, small people have small babies. That's normal. Large people have large babies. But malnutrition, we'll see malnutrition a lot in the drug addicts. And I've had a lot of drug addict patients deliver. And they're malnourished because they're mainly just using drugs and they're not thinking about the food they're taking in. So I've seen a lot of malnourished, and the baby ends up suffering as a result of that. Maternal conditions, PIH stands for pregnancy-induced hypertension. Now, if this goes uncontrolled, there's a decrease of oxygen to that placenta. So that's what's happening. PIH, she has sky-high blood pressure, so there's vasoconstriction throughout her body. So now we're having a decreased amount of blood supply get to that placenta. Chronic hypertension, if the chronic hypertension is not being well controlled throughout the pregnancy, again, that can be a contributing factor. If a patient's diabetic and we're not controlling this diabetes, and we always expect these diabetics to have these big, plump, LGA babies, these large babies. When we have a diabetic who's not been well controlled with the glucose control, these babies come out IUGR. And it's the same reason. The vascular, the high blood sugars, it's causing, once again, a decrease of oxygen going to that placenta. So actually a diabetic can have a little tiny IUGR baby, and I've seen that too many times. Okay, does that make sense? So IUGR in a nutshell. So maternal factors, and they just kind of look at broad spectrum. They look at all those patients and what are some of the factors we see over and over and over again. Primates, ground multips, smokers. I used to beg patients, please just stop smoking for the pregnancy, because every time you light the cigarette and you start smoking it, it constricts all the vessels in your body. So every time you smoke a cigarette, you're decreasing oxygen flow to the placenta. So we actually at Kaiser, they'd have no smoking classes and ways to help pregnant patients at least stop smoking for the pregnancy. Age extremes, my oldest patient, natural blood was 48, not in vitro. Like they'd raised all their kids, this was a surprise baby. So, or like a teenager, a young teenager who's concealing the pregnancy. I've had a lot of patients that nobody knows they're pregnant until they're in labor and they're in the ER for abdominal pain. So, I know it's really sad. Lower socioeconomic status and then high blood pressure. So these are your main maternal factors that they see with IUGR babies. Environmental factors, high altitude, excessive exercise. You know, there are people that have eating disorders and they're exercising. I don't know if you've ever known anybody that's anorexic. I've known professional people who are anorexic, and they're always over-exercising. Okay, so this is another predisposing factor. And then some medications. We always would tell our patients not to take any medication unless you talk to the doctor, because of the teratogenic effects that could be occurring with the fetus. So this is really important, even with herbs and natural things too. They should always be making sure it's conducive to the pregnancy. Fetal factors, congenital malformations, infections. So infections would be like the torch infections, chlamydia, our STD infections as well, and then placental factors. At the placenta, at the previa, we'll talk about that more in Module 4. There's different types of placenta previas. And then abnormal cord insertion. Sometimes the cord is not inserted in the center of the placenta. Sometimes it's at the edge of the placenta, and then the baby's not going to get the normal amount of oxygen it would as if the cord were in the middle of the placenta. Okay. If you ever get to see an abnormal cord presentation, if you hear about that, run and look at that. It's really interesting. So here's a little IUGR baby. This baby's tiny. And I can't really tell. I got this slide off of it. It was for a presentation to doctors. But that's a little IUGR. They kind of look like a little old man. Okay, then these are twins. These are called discordant twins, where one baby's getting the majority of the blood flow and the nutrition and the oxygen, and then the other baby's getting kind of ripped off. Poor baby. And that baby's having a retraction. See this baby hustle? A little retraction. You got a retraction. Yes?
Wondering how come placenta previa can cause it?
IUGR?
Yeah.
Because when you have placenta previa and they have episodes of bleeding, then the bleeding is always taking away from what's going to the fetus. So previas usually have these bouts of bleeding. I've taken care of a lot of previas where you're trying to get them to be close to full term, but they have these bleeding episodes, so that's why. Good question. Okay, so these are discordant twins. So in antepartum testing, how many of you been to the maternal fetal testing center? Are they testing any twins? Okay. I was at one point testing 3 sets of twins for this small company back to back. And you're always checking out the small baby. When you have discordant twins like this, they usually pick this up on ultrasound. You're mainly watching to see when this small baby needs to be delivered. Because we can see this baby is not getting anything compared to what the larger brother's getting, so. So we'd be watching that little baby be like a hawk. Okay, so SGA is different than IUGR. SGA just means small for gestational age. And they are below the 10th percentile on the growth chart. So an average baby, according to our book, says 7 pounds, 8 ounces. That's a normal average baby. So SGA used to be considered 5 pounds, 8 ounces and below. So I'm not sure exactly how it's defined, because it's probably close to that. But anyway, our little SGA babies, they can be a preterm baby, they can be a full term, they could be overdue, but they're just small. So it's really it's important to understand they're just small babies. Okay, IUGR have had a reason why they're like little scrawny little men, because there's been a growth restriction issue. These babies have no identified issue, they're just small, okay? They're small for gestational age.
So it could just be the small parents? Maybe?
Yeah, it could be, potentially, yeah. If you have a little tiny couple, they have a little tiny baby, I'd be like, well, they match, you know? But yeah. Okay. So SGA babies are at greater risk for perinatal asphyxia. So that's like during labor. They're at greater risk for suffering chronic hypoxia. But we would see that on our fetal monitoring strip by what? What kind of decelerations would we be seeing? Lates, yeah. Aspiration syndrome, hypoxia can cause fetus to gasp during birth. So they might aspirate amniotic fluid and into their lower airways. So again, did it have any of you in the delivery room seen the physician sucking out the baby really well prior to the body being delivered? Yeah. That's why it's so important to do that and to have that time to do that before the body's out. Polycythemia due to poor intrauterine oxygenation. They produce more erythrocytes. So, and then the erythrocytes, we know, only live 2/3 as long. And so, they're more at risk for that. Okay. Okay, so SGA babies, we're going to be testing them with AfriChecks. They fit our protocol. They have little storage of glycogen. And then hypocalcemia in response to birth asphyxia, if they have that occur. And then heat loss. They have less muscle mass, less brown fat, so they're at greater risk for getting cold. So you want to be really careful with them. Okay, LGA babies. Have any of you had LGA, a large baby? LGAs. I'm not sure at Fountain Valley. I think it's around 9 pounds that they're going to test them. But they have, it's usually in kilograms, like it's grams. 4,000 gram baby is usually an LGA baby. So, but it's 90th percentile and above. So our large babies, same thing with the small babies, we're going to be doing AfriChecks because they have an issue with blood sugar. They're at much greater risk for the shoulder dystocia to happen, for them to fracture the clavicle during birth. So we always we palpate clavicles, right, on the babies. We just touch those little tiny clavicles. With these large babies, it's really important to palpate those carefully because they can have a fractured one if they're doing a vaginal birth. Okay, and then I have a slide showing damage to the brachial plexus, facial or phrenic nerves. So their little arm will just hang. It'll be completely like, the babies, we like to see this, right? This motion when little babies are laying there, good muscle tone. When they have an injury, this little arm just hangs. And there's a slide on here that shows that. Cephal hematoma, they're more at risk for that just because they're big. And yeah, getting them out. I know the one delivery we used the vacuum. Yeah, that baby was 8 pounds, 8'1", but she was a pretty small mom. It was a pretty big baby for her. So, and then the vacuum can cause cephal hematoma. We're using the vacuum assist. And then bruising is more common. So we have a much increased rate of C-section. In fact, you're seeing C-sections nowadays for macrosomia, which blows my mind because unless you allow a trial of labor, You don't really know that that baby's too big to fit through mom's pelvis. But they're actually doing quite a few C-sections now for macrosomia. Have you guys seen that in any of your patients? Yeah. Okay. All right, we can stop here. Yeah, let's stop with our LGA. Take a break, and then come back at 1. Okay? If they have both arms flexed, both legs flexed, that's normal. That's the kind of tone we want to see. This is completely absent in this affected arm. So we would be documenting this like crazy. This can be permanent damage. It's just really going to depend how severe the nerve damage is. Isn't that so sad? And sometimes they'll completely recover. Last semester I had a student in here whose baby had that injury. And now her child was about, I think, 6 or 7 years old, and it was completely restored to normal function. So they have the potential to make it come back.
But then what we have to do to be able to
It just slowly healed. I mean, we're talking about nerve damage. So
From birth? From delivery?
from the delivery, when you deliver an LGA baby, you run that risk of the clavicle breaking and then the nerve being completely damaged. So, yeah, when you're in doubt about a macrosomia baby being a C-section delivery, if this is your potential outcome, you want to avoid that in a C-section, definitely. But, yeah, I've seen a lot of babies, not a lot, but enough to remember that you're just like, oh, wow, you can tell this baby's arm, affected, there's no movement in that arm. So, okay. Brachial plexus injury. Poor baby. Okay, so hypoglycemia is what I see as the bigger issue with the LGA babies and oftentimes the SGA babies. Yeah, they just continue pumping out the insulin and it drops their little blood sugars down. And polycythemia, another issue. Okay, so the typical diabetic patient with the LGA baby, these babies are large due to the excessive weight of visceral organs, cardiomegaly, and increased body fat. So they can be really, really big. Have any of you had a diabetic patient with a big baby? Okay, yeah, we've had a couple. Decreased body water, they have excessive fetal growth due to the high levels of maternal glucose. The insulin acts similar to growth hormone. That's what's interesting. So once in cells, glucose is stored as glycogen. Right. And then the common complications of the diabetic mother and on the baby is hypoglycemia, hypotoxemia, and hyperbilirubinemia. So our diabetic moms, these babies are watched very carefully. Whether they're an LGA baby or an SGA, whatever they are. If the mother's diabetic, we're going to watch these babies for these 3 things. We're going to watch them really carefully. Birth trauma is very likely. We just saw the slide of the baby with the brachial plexus injury. Polycythemia due to the decreased extracellular fluid volume. And then respiratory distress syndrome, you might just see RDS on a chart, or hear a nurse say, oh, the baby got RDS. So they can actually be a big LGA baby who's actually having trouble breathing. So we're going to watch those babies, have an O2 stat monitor on them, oftentimes give them supplemental oxygen to help them transition through. Congenital birth defects are much more prevalent with diabetic moms. So they're going to have more ultrasounds done. They're going to be watched much more closely. Okay, so what are we monitoring? We're monitoring vital signs for hypothermia, for respiratory distress. So the main 3 respiratory distress, retraction, nasal flaring, and grunting. Those are the 3 classic signs. And then with hypoglycemia, we've already talked about this with the jitteriness, high-pitched cry, poor muscle tone, poor suck, low temp, and tachypnea. Jitteriness and tachypnea are the 2 most prevalent signs with hypoglycemia. But if we hear a baby crying and they have an extremely high-pitched cry, that can be due to the low blood sugar. So we want to pay quick attention to that. If the baby doesn't have the good muscle tone, the baby's just kind of floppy, we call it. Again, it could be that the baby's blood sugar is really low. So we definitely want to assess their blood sugars. And then if they have the low temp, anytime they have a low temp, we're going to be thinking in the back of our mind, maybe hypoglycemic. Okay? Okay, and then we're always going to be assessing these large babies for a fractured clavicle. That's why when you're palpating clavicles, be very, very careful and real precise. And when in doubt, ask somebody else to check the clavicles for you if you think there might be an injury there. All right? So for hypothermia, we're maintaining our warming measures. Are you all attaching the skin probe to the baby's skin and switching over your warming unit? It's really important to do that. Rechecking the blood sugar in 30 to 45 minutes after the feeding or intervention. And then we will recheck. If it's staying low, if we have a baby's blood sugar, maybe it's like 30, 31 the first time, we recheck it, feed the baby, it's staying in the 30s. Any baby that's really having a blood sugar issue is going to go into the NICU. Okay, we're not going to keep that baby out in the regular newborn area because that's a sign that there's something going on. That baby probably needs to have an IV and to be assessed by the neonatologist. So if less than 40 or 45, every policy and procedure at each institution will have a different protocol. So it might be 40 is their cutoff where they want to do an intervention. It might be 45. In England, it's 46 because it's one study that I was looking at. But we want to maintain adequate hydration, 65 mLs per kilogram during the first 1 to 2 days of life. Hopefully you're putting that on your newborn Concept Max helmet. How many mLs should our patients be getting in little babies? You should have an idea, and it's all by weight. And in pediatrics, everything is by weight per kilogram. Okay. Oh, I have this. Have you guys seen this handout? This is a handout we give to moms oftentimes. It's showing the size of the newborn stomach. So this is a little marble. This is how big their little stomach is for that first feeding. So we don't want to give them any more if we're giving them formula than 15 to 20 ml, okay? Because it takes time. We want to stretch out their little stomach gradually, all right? And then this is how big it gets after the first day, and then it should be the size of a ping pong ball in a couple days. But it's just a nice handout to show patients, because you know how patients really want to feed their babies a lot. Makes them feel good or something, I don't know. But yeah, we just want to show them your baby's stomach is really tiny. So this is just a nice handout from one of the formula companies. Okay, so what else? Okay, where do I have one? Okay, this is just showing a preterm baby's skin compared to a postterm baby's skin. And see here we see the baby with the cracked, peeling skin. And that's really normal. If your baby's overdue, you should expect them peeling all over the place. And then the pretermer skin is usually much brighter red and really, really thin. You guys get to go into the NICU in the next day. Okay, we'll go over the feeding. Okay, so for breastfeeding mom, if you're trying to sell a patient on the ideal of breastfeeding, these are some really important points to tell the mom. If she's like, no, I don't know how to breastfeed, I could formula feed. These points to show how much better breast milk is is actually better than formula. So if we can get our moms to breastfeed, we want them to breastfeed, of course, at least for the first couple months, hopefully for at least 6 months. But anyway, the amino acids, the protein, the carbs, and breast milk are so perfectly formulated for the newborn. And it's really good for nurses dealing with the moms that you can speak to this, that you can give them the facts and help them make a good decision regarding their baby. Okay. And then calories. These are fluid needs you should all have memorized. You should know, when we're talking about the newborn, how much should these babies be getting? You need to pass that on to the parents. This is how much your baby should be getting by 7 days of life. For the first couple of days, it's a lot less because we're stretching out their little stomachs. And we need to be teaching them that as well. Okay, and then prolactin does what? Yeah, prolactin is directly connected to milk production, and oxytocin is directly connected to what? Yeah, the letdown reflex. So it's important to know that these are the two hormones that we should be able to speak to that. What is prolactin and what is oxytocin? We should be able to say that. And then baby needs to be in really good position while sucking to be able to drain the breast tissue. And then this just talks about colostrum. And I've told so many patients this because many patients are under the misconception that until their milk comes in, the baby's not going to get anything from this colostrum. I've had a lot of Hispanic moms that think until the milk comes in, this colostrum is useless. But the colostrum is actually really, really valuable to the baby. You know, it's high in calorie, it's high in protein, but it conditions the intestines. And that's one of the big things. It's really good for their intestinal tract. So we want to be speaking this to these patients in words they can understand. This is going to help your baby to have its first meconium stool. You know, we really want your baby to have that first bowel movement before you go home. But the biggest win-win for babies is that they're going to get mom's immunities passed through the breast milk. Because babies don't have a really strong immune system to fight germs or fight pathogens. So getting mom's immunities, that's what I used to tell patients. You're going to pass on so your baby can fight just common colds, the flu bugs, etc. All right. And then transitional milk, you know, their milk's going to change from the colostrum to transitional before the actual milk comes in. So this is all teaching that we need to be able to teach them about and what to expect. Okay, mature milk is after 2 weeks. Okay, and then just the components of breast milk. What it does, it's really important. How many of your patients are breastfeeding at your facility, would you say? Most of them? Few formulas? Yeah. Yeah, I think people are breastfeeding a lot more nowadays than prior. And vitamins A, E, and C are high in breast milk. C is low. But the minerals, this is huge because you try to put this iron into formula, and it really causes GI disturbances in the newborn. So I would tell patients, I wouldn't give my baby iron. They get much more GI disturbances. They're crying, they're fussy. It's because we try to add that iron into the formula. It's not good until they're a little bit older. But the enzymes, it's just way better. So these are signs of infant problems with breastfeeding that we can help identify while our patients are still in the hospital. If they're falling asleep in less than 5 minutes, that's an issue. They're obviously not getting a lot, and the sucking is just putting them to sleep. If they're refusing to breastfeed, there's something wrong there. Because once the baby latches on and actually tastes the breast milk, they like it. It's way sweeter than the formula. If they're doing tongue thrusting, which means they're kind of pushing the tissue out, smacking or clicking sounds, we shouldn't be hearing anything like that. We should be hearing a really nice swallowing. And then dimpling of the cheeks, we shouldn't be seeing the dimpling of the cheeks. And then failure to open their mouth wide enough to latch on. All these things, there's lactationists, I believe, in all 3 facilities now that can actually go and work with the moms. And I used to be the lactationist, like I would do all this with our patients at the desert because we didn't have a lactationist. But we learned how to totally teach patients how to breastfeed and to be very successful with it. So as students, you guys can be really key in identifying problems and letting your nurse know. We don't expect you to be able to be, all by yourself, functioning 100%, but you can help your nurse identify it and bring it to our attention. These are more of the problems: lower lip turned in, short, choppy motions of the jaw, and no audible swallowing. If you're not hearing the baby actually swallowing, there's a problem, and so we need to work with it. Use of formula. We don't want to use formula if they're going to breastfeed because of the nipple confusion. Once you give a baby a plastic nipple, it's just so easy for them to suck the formula out of that, and compared to working at the breast tissue. So we really want babies to learn how to work really hard to breastfeed. If you're going to give formula, and I was in a patient's room, I think it was with Van, was it your patient Van, where they were bottle feeding? I don't know, I'm in so many rooms. But anyway, yeah, they were giving this baby so much formula and she wanted to breastfeed. So it's not a good thing to do if they want to be successful with breastfeeding, is giving them plastic nipples.
What about the pacifier?
Pacifiers, I think, are great because it's they're not getting food out of it, but they're sucking, helps just to cause them to be at rest. It's like a really conducive thing for helping the baby to calm down. So I personally think pacifiers are great if you're going to breastfeed, because you don't want the baby using a breast like a pacifier just to have that extra sucking. Because some babies need more sucking than others to get them to calm down. So yeah, I think they're great. I'm sure you'll hear mixed reviews. Maternal problems, hard, tender breasts. When the milk comes in, they get engorged. Painful red cracked, blistered, or bleeding nipples, which happens to a lot of patients. Flat or inverted nipples, although they can still breastfeed if they have flat or inverted nipples. It's very doable. Localized edema or pain in either breast, which is probably mastitis. Or these are signs and symptoms of mastitis, the last two. So you want to get her treated if she is developing mastitis. But the baby can still breastfeed. Okay? All right. Any questions about any of that? Yes.
Colostrum and the mature milk, how do they know? Does it look different?
Yeah, the mature milk is thicker in consistency. Yeah. The transitional is real thin. Thin milk? Yeah, good question. So, okay, so I put up on the board over there APGAR. So I want a couple people to come up and write what constitutes an APGAR score. Somebody brave. What constitutes an APGAR score? There's 5 parameters that are measured. Okay. Thank you, girl. Okay, go ahead. List all 5. Because everybody needs to know this. So the heart rate, and what is the rate we're looking for? 100 or above will give how many points? 2. 100 down to what is 1? 60 to what? 60 to right below 100 is a 1. And then below 60 is 0? Okay. So I got heart rate, respiratory effort. Did you guys put that? I heard you say respiratory rate. You guys are doing good. Okay, what else to say? We have heart rate, respiratory effort. What else? Color? And color, what do we want to see with color? Pink for what? Everything pink, right? It's 2? So what's a 1? Pink with acrocyte, so this is a 1. Okay. And then if they're not pink, that's a 0. And that's bad. And then reflex irritability. Who said that? Who said reflex irritability? Or reflex response? Yeah, you're going to see different. And what are we looking for there?
Strong cry.
If they have a strong cry, that's what for reflex? 2. And then what's a 1? What? Weak cry is a 1. What's a a 0? No cry. We're in trouble. Okay, let me see what they have. Oh, good. Very close. Agreements, activity, respiratory effort. That's good. That's a good way to remember. Yeah. So did you see this? Appearance, pulse, grimace, activity, and respiratory effort. Okay, so respiratory effort, good cry, weak cry, no cry? Or is that reflex irritability? What about muscle tone? What are we looking for in muscle tone? Yeah. Limp is bad. What is limp? 0. So what's a 1? Muscle tone. So sluggish movements or kind of lethargic movements. Have any of you seen a baby where the muscle tone isn't good? Yeah. And it's noticeable when you're used to looking at all these normal babies with good tone. It is scary. It's not good when your baby is not exercising good muscle tone. Okay, so your APGAR score, you should know that by heart. You should know what we're looking for. So if you have a baby that's pink, crying, moving extremities, what's going to be the APGAR? A 10 if you're just giving pink, if you're not giving acro. So pink with acro, crying, moving all extremities, that's a 9. Okay, so if you're giving different points in a stem of a question, you should be able to calculate the APGAR score. Okay.
Are most healthy babies a 9? Because it seems like everything I've seen in the chart is a 9-9.
Yeah, or an 8-9. 8-9 is really more common at the 1 minute. Yeah. So,
They don't come out till 15.
right. And it takes them, they have to use their lungs to be able to turn pink. Because all babies, when they come out, you've probably seen them all, they're all kind of a purplish blue color. I always explain that to people when they're like, oh my God, my baby. I'm like, it's normal. That's what color the baby was in the uterus. Once they start breathing with their own lungs for the first time, that's what causes them to turn pink. So it's a teaching issue. Okay, did you guys get them all? How are they doing, class?
I don't know where failing at.
Okay, so grimace reflex. For a 2, what was it we said a minute ago? What's a 2 here for good reflex?
They said 11.
It's like a loud cry.
Sneeze and cough.
Yeah, if they cough or sneeze, that's a 1, right? Is that what your book says?
Is that 30 to 60 or less than 60?
Less than 60 is 0. So if they have a heart rate between 60 basically and 99, it's a 1.
The respiratory rate should be between 30 to 60.
Respiratory effort. It says effort. So respiratory effort. So how's your book? Are you looking at the APGAR score in the book? That's why I go by our book for everything. Because otherwise you're going to see a variation in every source you look at.
Did you say a sneeze and cough was 1? 2.
Is it 2 according to your book? Okay, so go by that. We used to actually have APGAR scoring charts at the head of every warmer in every delivery room. But they've since taken those down. Yeah, you can show her the book. I know that we have a nice APGAR in the book.
Is there an assigned number for the respiratory rate?
No, it's not a assigned number to my knowledge. It's never been an assigned number. Oh, yeah. So minimal response. infections. I want you to look them up, and I want somebody to come up here and write them up here. Torch infections. The torch infection. And all those stand for something. T stands for something, O stands for other, R stands for something, C stands for something, and H. I'll write the first one. I'm just writing the first one. These all stand for something. You just need to be familiar with these. Toxoplasmosis. If a mother contracts toxoplasmosis during her pregnancy, it has an extremely detrimental effect on the baby, to the point of death. Okay? I know, you guys. Come on. Yes, go for it. How many of you have cats? How many of you have cats? Anybody have a cat? Who has a cat as a pet? Why do we tell pregnant women not to change the litter of a cat box when they're pregnant? Because why? What can happen is they can contract toxoplasmosis. Okay, so I do the prenatal classes for all of our incoming group of patients and teach them about toxoplasmosis. If they have a cat, have somebody else change the litter because you can contract this from cat feces. Okay, so this is something really important for pregnant women just to be aware of. If they have a cat, I love cats. We don't have a cat now, but we both have cats. Okay. Good. Good, yeah. So we have, so the others, the O and torch for other syphilis, varicella zoster, and maybe even measles. No, here's rubella. Rubella is the R. They contract rubella during pregnancy. It's really life-threatening to the baby. Cytomegalovirus, CMV, called. This is very bad for the fetus. And then herpes. We know herpes can kill the baby. So you just need to be aware of these infections. They've been identified for a really long time as potential pathogens that could harm the baby during the pregnancy, and if they survive. Herpes after they're born, they can die within a matter of days. Okay, so this, if you have this handout that Monica gave you, I just want to highlight a few things on this. It's really good for study. And your book does talk about the torch infection. I just don't know what page it's on.
What's the heading on
It's
that?
on page 657.
657. Okay, on this handout, just because I think it's a nice study guide for you, in the upper left-hand corner has got the APGAR scoring, the 5 parameters, and then right down here on the left side, it's got the 10 regarding our ineffective thermoregulation issues. It's got the 4 types of heat loss, which you need to be, you can speak to those. Also, the bottom corner down here, it talks about what happens when the baby gets cold, pathophysiology-wise. This is an excellent little box just to kind of sum it up. Why, once the baby's cold, it's going to cause the baby to drop their blood sugar. Okay, and then At the top, right here, it says how much sleep babies need, 16 to 20 hours a day for the first couple weeks. On the general characteristics, it's giving you some really good points as far as average length, weight. Talks about molding. You should know what molding is. You should know what caput fecundum is. Sepal hematoma. It mentions fontanelles. If the fontanelles are not flat and they're bulging, is that a bad sign? If we have bulging fontanelles? Yeah. That's a sign of increased intracranial pressure. So that baby would go to the NICU. Okay, we have a baby with bulging fontanelles. Gone. Possibly, yeah. Potentially. So you should know the fontanelle. The anterior is diamond shape, the posterior is triangular shape, and you should be able to palpate those by now. What else? The umbilical cord has 2 arteries and a vein. Everybody should know that. What else? Right down here, I like what it says. Within the first minute of birth, loud, lusty cry, no dyspnea, no retractions. This is just really great little, what we're anticipating in a normal newborn. What are the characteristics? So I just wanted to bring that to your attention. Also, where these 2 stars are, right here in the middle of the right side, it says extremes in size may indicate microcephaly, hydrocephaly, or ICP. So if the baby's head measurement and the chest measurement, there's a distinct difference, these are a warning sign that there's something not right with this baby. So I thought this was an excellent little study tool for you for the newborn module. All right? Any questions about that? Yes?
Reading the book of Second Fontanelle sign of dehydration.
Yeah, sign of dehydration.
How do you do that?
How do you what?
What's the intervention for that?
Yeah, probably go to the NICU and get an IV. Yeah, if a baby's born with sunken fontanelles, we're talking about a baby that's not...
Babies would be okay if there's only 2 vessels in the cord.
Actually, all the babies I've seen with the 2-vessel cord have been fine. But if there is a 2-vessel cord, you want to alert the pediatrician that this baby only had a 2-vessel cord. But yeah, all the ones I've seen, and I've seen many because of all the years I did it. Good question.
So what, doesn't one work with the artery and the other one's vein?
Yeah. Yeah, instead of having the 2. And then the next page on this, it just shows sepal hematoma, which you should know the difference between a sepal hematoma and caput. So this is just really nice. This is really nice study information, I think, for you for the next exam. So, all right. So I'm going to give you time in your groups right now, and this is what's going to happen. I want you to get into your group. I have a form I want you to fill out for your group. I want you, if you haven't already designated a leader of your group, I want you to designate a leader. Every group needs a leader, okay? Because that way you won't be overlapping on the information you're getting. Everybody needs to be contributing, okay? So, okay. I want you to do this meet. This is going to give me your scenario. If you haven't already talked to me about your scenario, these are coming up really quickly. That's why I'm giving you some class time today. Okay? Okay, right, so, I need one person for every group. So you don't have permission to leave. Did you get signed up?
Yes, I did.
Okay, good. Okay. Yeah, it's really good to go over ahead, but it will just help you identify, like if you're changing answers or if you're missing something and it's done in the lesson like that. Okay? No.
Can we just
I'm going to tell you right here what I want.
Okay, awesome.
For testing. Looks 14. Good.
Yay, thank you, Prof.
You're welcome. Yeah, so we're just, okay, so I'm supposed to be geared more towards like Right outside. We're good. That's fine. Yeah. All right. I just need your paper. have to go. We already met with each other a couple times. Oh, that's great. Done. Super organized. We have two patients, two nurses, a doctor, a narrator. Patients coming to see the doctor. Like they each have two other honey. Yeah. Right out of woman. Oh, yeah. And they hook up with each other. Okay. Now they're going to yell at psychosis. Okay. That's great. And then there's three pictures. So, like, and I'm doing like this. I'm putting everything together and I'm going to kind of introduce things, close it out. And then Nina's going to do the narrative. Yeah, and then Nina, like the doctor, he's going to images with PowerPoint too. Okay. And then like we're not doing all the training. Okay. Perfect. Patients are looking at all their systems. Okay, good. So I just want to write it for you. Yeah. So if that works, that's perfect. That's perfect.
Rodney. Hello, Joaquin, Joaquin. I love you, Joaquin. Give me a call after class. I love you long time.
I love you, long time.
So we're just doing everything that has to do with describing it, how it's going to be used.
Okay. Awesome.
Technically, we all need to talk for at least 2 minutes.
Yeah. Well, I take your cat. I take your assistant. I'm getting a cat. I'm getting a cat. Are we going to look at the test?
You are, right? You also so forgetful that you got all this stuff.
Oh, no, that's not going. That's very easy. You want to move up?
This is Joaquin's phone, and it's going in the trash, right? About yeah.
That's funny.
Scary?
Yeah.